Now I would like to invite Dr. Nikhil Mehta from All India Institutes of Medical Sciences, Delhi, and he will talk about long-term outcome and patient satisfaction with vitiligo surgery. Dr. Nikhil.
Okay, good evening. My presentation is on long-term outcomes and patient satisfaction with vitiligo surgeries. So we did this study as there is not much data available in this area. Percentage repigmentation is the primary outcome in most surgical studies, but undesirable pigmentary outcomes in patient acceptabilities are usually neglected. The usefulness of multiple surgeries too has not been studied. So we undertook a cross-sectional study where we contacted all patients which we had operated at our tertiary center in the last 10 years, the duration for which we had the records. And recorded details in the domains of demography, efficacy, including patients' assessments, adverse pigmentary outcomes, quality of life, and impact of multiple surgeries. So coming to results directly, the consort diagram, excluding the missing or unreachable contact details and those who did not consent, we recruited 116 patients with 158 surgeries, out of which 88 had undergone a single surgery and the rest 28 multiple, with their average being 2.5 surgeries per person. We had a median follow-up of 3.5 years and almost equal distribution of segmental and non-segmental disease. Most commonly operated sites were face and neck, followed by acral areas of the leg. NCES, suction blister grafting, and mini punch grafting were the most common procedures. Greater than 75% repigmentation was seen in 65% as per physician and 59% as per patient's assessments. Obviously, segmental responded better. In the 3.5 years median follow-up, only 9% had recurrence at the operated site as well as disease activity at other sites, while only the latter was seen in a further 10%, and in those 10%, the operated site remained stable. Moderate to severe color mismatch, variegation, marginal hypo and depigmentation was seen in 31%, 19%, and 48% respectively, and was significantly bothersome in 25%. Donor site healed with normal color in 80%. At the follow-up duration, the impact on the quality of life of the disease had significantly decreased. The surgery was considered to be successful in 82% by physicians and 69% by the patients. Noticeability decreased in 79%, and 70% of the patients thought the surgery was worthwhile despite the undesirable pigmentary effects. Multiple surgeries were done either to cover leftover lesional or extra-lesional area or for marginal depigmentation, which occurred despite being covered in the previous surgery, or to correct the adverse pigmentary outcomes. Further surgeries increased the extent significantly in 70%, with 82% finding it worthwhile with reduced noticeability. Repeat surgeries improved the adverse pigmentary outcome significantly in 42% and led to some improvement in a further 25%. Some examples: good color match with satisfaction, color mismatch, still the patient was highly satisfied, color mismatch as well as variegation and marginal hypopigmentation, but the patient was satisfied. Coming to discussion. As we discussed in the afternoon, we can't give patients what they want, but do they accept what we can give them? The correct way to assess that is by measuring impact on QOL with specific patient-reported outcome measures, which was not possible in this retrospective study. Many of our patients' procedures actually preceded the development of many of these prompts. So, we use global questions to measure QOL, and we indeed should measure it, as there is considerable discordance between the patient's and physician's assessment. This study had one of the highest follow-up duration and detailed assessment of the adverse pigmentary outcomes and quality of life assessment compared to the previous studies. It surprisingly showed a lesser improvement in QOL compared to other studies, which might be due to the lesser proportion of patients with good repigmentation, or we operate more acral sites. In general, skin of color patients have a greater impact of vitiligo compared to Caucasians due to the historical stigma associated with vitiligo. I believe that they tolerate the adverse pigmentary outcomes more if people around them don't perceive the disease to be vitiligo, even if it is adversely pigmented. The fact that 13 patients didn't consent as they were married post-surgery and their in-laws didn't know that they ever had vitiligo is the testimony to the impact of surgeries on the patient's lives. Patients with multiple surgeries had significantly more proportion of good repigmentation, consideration of successful surgery, and worthwhileness compared to the single surgery group. The adverse pigmentary outcomes were also brought down to the proportion similar to the single surgery group. Our center previously too had published the role of repeat surgery, especially NCES, to improve the undesirable outcomes of the previous surgeries, and we consolidated that finding in the study. To conclude, vitiligo surgeries reduce the impact of vitiligo on quality of life and should be encouraged in centers and for insurance coverage. Repeat surgeries further improve outcomes. Patients find surgeries worthwhile despite adverse pigmentary outcomes, and those adverse pigmentary outcomes can be reduced by further surgeries. The limitations were mostly due to the retrospective design. These are my references. Thank you.
Any questions?
Go ahead. Go ahead.
Very well done presentation. Are you doing quality of life measures now prior to surgery?
Yes, for the past 6 months, we have started using VIS-22 and DLQI with permission in the vitiligo surgeries.
So then a follow-up question, how long does it take for the patient to input the information, and then are you doing perception differences for the physician on the post-op visit?
Yes, so we are now following them for the surgery patients. We do follow them in 3 months, 6 months, and 9 months interval. And we are following the same for the questionnaires. So the pigmentary outcomes in terms of percentage repigmentation as well as the PROM questionnaires, we are filling the same time, 3 months, 6 months, and 9 months. And it takes 5 minutes to fill the VIS, and DLQI almost takes 3-4 minutes. So about 10 minutes to fill the questionnaires. And they agree. Most of the patients have agreed. Till now, I have not seen a single patient refusing to fill the questionnaire, except those were illiterate patients. So.
Thank you for your presentation.
Thank you.
I would like to that the results will be divided in 2 groups, non-segmental vitiligo and segmental vitiligo, and to compare both, because I think that it's not the same outcome and the same results.
We actually do have the data. I didn't put it in presentation
In
because
discussion,
it was
you did it in discussion, yes. Not in the results.
Yes, ma'am. Yes, ma'am. Actually, individual studies, we had too little sample size for that, but we can do that. We believe that comparing individual studies is not good because it gives a wrong impression. These studies are done for different indications in our center. So we reserve money punch for very limited indications like acral surgeries or fingertip surgeries. Section blister we do for lip or eyelids. So it's not right to compare these surgeries because the indications are different.
So you might want to have a more uniform population and just look at the NCES on its own.
Yes, sir.
So, Dr. Nikhil, it means in non-segmental vitiligo, these patients remain stable for...
So, out of the non-segmental vitiligo, out of the whole patients, 91% of the patients had stable in the 3.5 years of follow-up. And those 8 to 9% which relapsed, in which the lesions became unstable, mostly they were non-segmental acral sites. But even on those acral sites, if we consider those 19 leg patients which we did, 17 of them were stable at 3.5 years of median follow-up duration. So only 2 relapsed.
Okay. Thank you, Dr. Nikhil.